We've had a long afternoon, so everybody stand up and stretch. Get the blood moving a little bit before we get going. Yeah, the seventh inning stretch. I love that. Take your time. I'm gonna get started while you're up. Stay up. Please, stay up. Move your feet, get your blood going. My name's Annie. I'm the lung cancer screening nurse manager here at Rush. I've been in screening for a little over 5 years. I was at a community health on the north side of Chicago before I came here. And I'm going to talk to you all about the history, the current state, and the future of lung cancer screening, specifically as it pertains to people that are working in oncology and nursing and thoracic. As you may or may not know, annual low-dose CT for lung cancer screening continues to be proven effective for early detection of non-small cell lung cancer, but uptake remains abysmally low. So lung cancer screening, like I said, is an annual exam. It's recommended for people that would be considered high risk for developing lung cancer. It is designed to identify and so we can send patients for treatment in early stage non-small cell lung cancer. It's a low dose CT of the chest. It's quick, it's painless, there's no IV, it's easier than a mammogram. That's what I tell all my patients, at least. It's much easier to come in for than your mammogram. And it's a low dose CT, meaning it's less radiation than the CTs that we've been talking about for follow-up for your patients. The amount of radiation patients are exposed to for a lung screen is about equal to 6 months of background radiation. So 6 months of living life on planet Earth, you're exposed to the same amount of radiation as you are coming in for your lung screen. For most patients that meet eligibility criteria in Illinois specifically, it is free for patients. It's $0 out of pocket because we have really great Medicare, Medicaid, CMS reimbursement laws. It does vary from state to state based on CMS laws, but it's generally affordable, or there are options to make it affordable for patients. If your patient has a USPSTF applicable plan, so basically a non-union insurance plan that's newer than 2011, it's ACA compliant, they're also required to be $0 out of pocket. Most of your patients should be coming in for a lung screen and it should cost them nothing. We're gonna bill their insurance, but they should not have to pay for this. It's like coming in for a mammogram. And the reason for that is the USPSTF gave it that grade B, just like in school, ABCD. B is a high enough grade for effective screening and prevention and early detection that they're not allowed to charge for it. This is an older version of my thing, whoops. So lung cancer screening has been around for a long time, since 2011. The first study was published. We're gonna kind of go through all of this. The first study that came out for lung cancer screening was the NLST, the National Lung Cancer Screening Trial, came out in 2011, and it looked at a little over 53,000 patients, and it had very strict age criteria, very strict inclusion criteria in terms of smoking, status, smoking, pack your history, symptoms. It was a randomized control trial that looked at patients and sent them for an annual low-dose CT for lung cancer screening for 3 years, or an annual chest X-ray for 3 years. And as you can tell, the curves are back, but they're showing good news. The low-dose CT was much more effective than the chest X-ray at diagnosing lung cancers, and the mortality rate for lung cancers went down for the arm that was coming in for low-dose CTs. NLST results back in 2011, it showed a 20% in lung cancer specific mortality. So it's doing a good job at diagnosing lung cancer early. It showed that you actually only need to screen 320 patients to prevent 1 death from lung cancer. You can see my nice little graphic on the bottom there comparing low-dose CT lung screening to a screening colonoscopy to screening mammography. Those numbers kind of vary a little bit depending on the patient population and the study, but significantly less patients need to be coming in for a lung cancer screen to save more lives. And actually in 2019, an updated version of the NLST showed that even fewer patients needed to be screened for lung cancer to save a life. So only 303 patients need to come in for their lung cancer screening and be involved in these programs to prevent 1 death from lung cancer. So very effective. There were some misinterpretations of the NLST when it first came out. This is kind of where the screening issue began. People misquoted it, saying that the false positive rate for lung cancer screening CTs was anywhere from 70 to 90%. You will still find this misquoted occasionally coming up, even though it's been misproven, it's been talked about. I did want to bring it up again. That was actually the false discovery rate. That just essentially means we're finding lung nodules in 70 to 90% of patients, not we're finding lung nodules that are specific that need to be followed up for surgery or additional imaging. The actual false positive rate on the original NLST study was only 23.3%. And the current rate is even lower. It's 10.4% overall. Actually, the annual numbers are 9.5%, and then baseline lung screens is 20.1%. So very low, depending on whether it's your first or a post baseline lung screen, low false positive rates. The American Academy of Family Physicians did not recommend annual lung screens in 2013 when the USPSTF came out with that initial B grade. They cited the fact that there was only this one study that had come out. The false positive rate was too high. The potential for overdiagnosis of lung cancer was too high. So they just said, we're just not going to push this. They're not going to say we shouldn't do it essentially, but they did not recommend that the family physician, so your primary care providers, they did not recommend that they recommend this to their patients. Lung cancer screening has standardized management. The first lung rads came out in 2013. Lung rads 1.0, I have up here lung rads 2.1, which is the most recent one. There's been 3 iterations of this, but what this does is it allows the radiologist that's looking at low-dose CTs, because we are screening such a specific patient population, to categorize the lung nodules that are found into very well-defined criterion. So 0 being, we can't get a good look at this picture for whatever reason. The patient could have an infection, inflammation, there could be motion artifact. They can't evaluate the nodules effectively. We got to bring them back. Lung rads 1, completely benign, not suspicious at all, negative. Usually that means there's no lung nodules essentially found. A lung rads 2, completely benign. We're bringing both of those patients back in a year, and they should come back for their annual lung screen so we can compare them. Moving on to the more positive standardized management, we go from 3, 4A, 4B, 4X, gradually getting more and more suspicious. They clearly define what the size is, what the shape is, whether it's solid versus non-solid, whether it's baseline versus growing, and then exactly what the follow-up should be for those exams. So it's really easy. It's designed to be really easy to manage these patients in a standardized way. So again, we're not sending patients for additional screens or surgeries or biopsies that ends up with that false positive result. The original lung cancer screening eligibility guidelines for coverage came out in 2 separate years. So CMS I talked about, and USPSTF, that's your private insurance. So this is the guidelines to get lung cancer screening free for your patients. The original guidelines. So you had to be between the ages of 55 and 77 for CMS, 55 and 80 for private insurance. Most patients between 77 and 80 have some sort of a Medicare, Medicaid, or supplement plan. So for like practical reasons, 55 to 77 was the original. They had to have a 30 or more pack year smoking history and be currently smoking or quit within the last 15 years. CMS had a few additional requirements that required to be documented. The patient had to be asymptomatic. There had to be a written order with a whole bunch of information included in order for this to be compliant and covered by CMS. Didn't quit there. They require a separate shared decision-making visit with a provider. So this is a physician and APP, a licensed provider, separate visit, including all of this documentation to ensure that the patient understands the risks and benefits. They require and continue to require use of a shared decision-making tool or aid that's also documented in there to prove that you did a good job. And this is how you showed the patient, because a discussion isn't good enough for lung screening for CMS. CMS also required lots of strict criteria for where you could come in for your lung cancer screen every year. So you can't just go to your community hospital. It has to be somewhere, or your imaging facility down the street. It has to be somewhere that can prove that they are doing low dose CAT scans. They're measuring all of this. They're sending that information in. They're submitting all of the patients with a CMS insurance to a national registry. The ACR, American College of Radiology, continues to have a registry for this. But you are required to take that time to submit that information to a national registry. And then there were more requirements placed on the radiologists that were allowed to read these exams. So essentially, there were some barriers set up when lung cancer screening first came out. I talked about the difference in age. So identifying patients that would be potentially eligible for lung cancer screening coverage is harder for primary care if you get one that is willing to talk about lung cancer screening with the patient. The written order meant that a lot of hospitals with EMRs even were creating a paper order for lung cancer screening because it said specifically a written order with all of this information included in it to prove to Medicare that these patients are eligible. There's required separate visits from the physician or APP to discuss shared decision-making. While the exam is free every year for the patient, shared decision-making is a billable visit with those providers. So they could potentially be paying for that. And then again, the facility and radiology requirements could potentially create a transportation barrier for patients, especially in rural communities. If you live in a rural community, your hospital is already 30 minutes away and they don't have the resources to staff somebody to submit to the ACR and review all of these requirements for the CMS orders. They're going to have to go now 60 or 90 or 100 or plus miles away to get their lung screened. So we're creating extra barriers by requiring these things for lung cancer screens. So we talked about pack years. The original requirement for lung cancer screening was 30 pack years. Pack years is not years smoked. That is not a number of years somebody has smoked cigarettes. It is kind of a complicated thing when you're talking to patients in real time, but you are looking for the average number of packs per day that they have smoked multiplied by the number of years that the patient has smoked. So you could have Mrs. Johnson who smoked for 45 years, but she smoked a quarter of a pack a day. She doesn't meet eligibility criteria, even if she's still smoking today, and she meets all the other eligibility criteria. The pack year history is something that's not often assessed or assessed accurately at provider visits. And it's difficult to diagnose, and it's also difficult. It's a long conversation to have with patients. They're feeling stigmatized the minute you bring up, do you currently smoke? When did you stop smoking? How much did you smoke? You know, you're getting those like falsely low readings when you're documenting and calculating pack years with patients. So, but it is a required eligibility criteria. Second study that we had come out that was a randomized control trial was the Nelson study. This came out just before COVID in February of 2020 out of the Netherlands and Belgium. Smaller patient group, vast majority of it was men. And they was a little bit different. They weren't comparing chest x-ray versus low-dose CT. It was usual care versus low-dose CT, and it wasn't an annual. The time frame was a little different. The patient population, in addition to being primarily men, they didn't require that 30 pack year minimum that NLST required. It was actually under a 20 pack year history, but you had to be smoking for a longer amount of time. So just a little bit different from Nelson to NLST. However, it did show a even greater reduction in lung cancer specific mortality. So it showed a 24% reduction in men. Interestingly, the N for women was just over 2,000, but it showed a 33% reduction in lung cancer specific mortality. So talking about that rate for women, not decreasing as steeply as it has been for men that we've seen in some of the previous talks today, like this shows even more that, you know, even with the small N, it's worth looking at and studying more women in screening. It did also prove a lower false positive rate than the NLST. So after that came out, we got new guidelines from CMS and USPSTF. They broadly extended the eligibility requirements for patients for lung cancer screening. So they dropped the initial age from 55 down to 50, and they dropped the pack year history from 30 to 20. So there's a whole lot more patients that can be coming in that are now eligible for a free lung cancer screen every year. Unfortunately, we still have those discrepancies with the age, the upper age limit, 77 and 80 with CMS and USPSTF, and they both continued to enforce the quit date within the last 15 years. CMS does have additional ones at the follow-up guidelines. They did make them a little bit easier. You don't have to have all that stuff required written in the order for lung cancer screening. Shared decision-making did not change the requirements. It has to be a separate visit. It has to include everything the same. However, shared decision-making can now be done by non-physician providers or non-APPs. So like nurses can do a shared decision-making with patients for lung cancer screening. So try to help to remove the barrier there. Again, the eligible facility guidelines got a little bit simpler, but including they don't require to be submitted to a registry. However, they do still require that standardized lung nodule identification. So that's that lung RADS that I reviewed. Everywhere is required to use those to standardize the follow-up care for lung cancer screens. And good news, the AAFP fully supported the USPSTF recommendations when they updated the recommendations in 2021. So yay, all the PCPs are now behind it. There's a lot of different guidelines for lung cancer screening that are out there. The two on the left, I kind of have this sorted from like most conservative to least conservative. CMS obviously being the most conservative with that upper age limit of only 77, quit date within the last 15 years. The farthest to the right, the NCCN has some guidelines where they, specifically in 2023, I believe they updated it. They just recommend screening for anybody 50 and up with a 20+ pack year history. They recommend shared decision-making as well. So you can like talk to patients and make sure like, is 80 a good upper age limit for you? If you have a healthy 80-year-old, if you have a healthy 90-year-old that's doing all of their other screens, they're going to continue with lung screening. It's going to be kind of patient-specific, disease-specific, as opposed to having an upper age limit as the requirement for screening patients. But the ACS guidelines and the NCCN guidelines, the least conservative guidelines are not covered by insurance. So patients that meet those eligibility criteria, but not the USPSTF or CMS, would not be entitled to that free screen every year. So a question that I get from a lot of people when I talk about lung cancer screening and we get into the pack year history and the smoking, what about screening based on other risk factors? We know radon exposure increases your risk of lung cancer. There's occupational exposure. What if they are smoking vapes instead of cigarettes? What if they're smoking cigars? What if they're smoking marijuana? What if they've had chest radiation? What if they've had other cancers? What if they have a lot of pulmonary disease? The answer in short is no. That would not make them eligible for lung cancer screening without meeting the minimum pack year criteria. The NCCN recommends including these additional risk factors when you're discussing shared decision-making, and there have been other risk prediction models that include some of this information to better gauge patients' risk for developing lung cancer instead of just high or not high to like, low, medium, moderate, high. But it doesn't affect essentially the ability of their exam to be covered. So it's worth noting, but it doesn't affect, unfortunately, who is eligible per insurance criteria. Currently, we're looking at lung cancer screening rates. Like I said at the beginning, our uptake is abysmal. In Illinois, we have a 5.6% screening rate. So we are screening only 5.6% of patients that meet those USPSTF eligibility criteria. Nationally, that's even lower. That's 4.5%. You can see the bottom line there on the dark blue one. That's 2. Look at all of those states that have a less than 2% screening rate. The high number there is 12. We're not even hitting 12 in the state that's doing the best. So we're failing our patients by not getting them in for screens. What can you do? How can you help? How can we get more patients in? The most important thing that all of you can do is when you are speaking with patients at the bedside, when you are assessing patients, when you're seeing them in clinic, when you're talking to them over the phone, taking the extra 2, 3, sometimes 5 minutes to accurately assess their pack year history will make a huge difference. If you accurately assess their pack year history, you put it where it's supposed to go in the EMR. Most healthcare institutions, Rush including, have flags set up for primary care where it will let them know, hey, your patient's probably eligible for lung screening. You should talk to them about this. And it'll pull up the shared decision-making criteria. It's all built in there for them. But until we have the information documented in the medical record, it's really hard to rely on primary care to add that one more extra step into their visit every year with patients. A lot of the times they just carry over, have your smoking habits changed, yes or no, and keep going. So by talking to nurses, talking to APPs, talking to providers, talking to MAs about accurately documenting pack year history, we can make a huge impact on the amount of patients that are at least told that they're eligible for lung cancer screening every year. Educate your patients, educate your providers. If you hear anybody misquoting that NLST number, please correct them. I had a patient literally last week over the phone who told me her former primary care, who has since retired, told her when she asked about lung cancer screening 7 or 8 years ago, no, you should not screen for lung cancer. It's too risky. They're just going to send you in for surgery and you're not going to have cancer. Or it would have been a cancer your body would have cured itself. Yeah, because that was the implication of misunderstanding of the NLST from 2011. That is still out there. This week I heard it. So be aware that is not true. The false positive rate is anywhere from 10 to 20%, depending on whether it's your first or your post-first exam. Partner with screening advocacy groups. There's a lot of wonderful groups. I know we've kind of talked a lot about these groups throughout the day today. I'm going to plug the Lung Screening Network, which I'm a steering committee member of. Connect with your lung screening navigators. If you are not actively involved or currently involved in lung cancer screening, you probably have a navigator at your hospital that's a one-off. Maybe there's two at your institution, and they are an expert in screening and guidelines and insurance and in tobacco cessation. It's required for shared decision-making. They know the resources for tobacco cessation at your institution. They're probably driving some of it or teaching those classes if that's what's available. We do it. Think outside the box, partner with other departments to increase your lung cancer screening rates. We have, you partner with cardiology and pulmonology. It's probably the same patients that are eligible for lung cancer screening are seeing a cardiologist or a pulmonologist. Partner with other departments that are involved in screening, mammography and colonoscopy. You've heard a little bit about Pink and Pearl. Every patient that comes into Rush for a screening mammography is asked a questionnaire to find out whether or not they would be high risk for mammograms. We added 2 questions into that screening questionnaire, which is like 30+ questions to assess if they would possibly be eligible for lung screening. We've identified over 200 patients in the last 6 months that could possibly be eligible for lung cancer screening that are already coming in for preventative care that didn't have that documentation in their chart. So think outside the box, partner with everybody. So current state, we're going to move on to the future of lung cancer screening. It's looking good. It's looking like we're following in the footsteps of the rest of the lung cancer treatments that we've talked about today. We are looking forward to precision screening, where we're more relying on deep learning models. We're looking at blood-based biomarker testing. It's all being studied right now to better assess and include more people in lung cancer screening. There was a civil study that was published last year where they had a validated deep learning model to predict future lung cancer risk from a single low-dose CT. So they took one low-dose CT from a huge patient pool, fed it through this deep learning model. It was a retrospective study, so they knew whether or not these people had cancer or not. And with no other information, no age, no gender, no smoking history, nothing, just a low-dose CT fed in, and it was able to accurately predict the patient's 6-year, the likelihood of them developing lung cancer within the next 6 years at a greater than 90% rate. So there's a lot of stuff coming in the future. Obviously, we have to do a lot more studies on this, but that was really exciting news for us last year. There's been other recent studies about mortality benefit of a blood-based biomarker panel for lung cancer screening and some other potential oncology screenings. We're looking forward to more of those. Some of this is in the process of FDA approval right now. And there are 2 studies happening right now, kind of switching back into getting women screened. The INSPIRE study is out of 2 cities. It's in Boston and it actually is in Chicago. At University of Chicago, they are enrolling patients, and that is for Black women ages 50 to 80 that have any smoking history. Doesn't matter when they quit, doesn't matter if they currently smoke, doesn't matter their pack year history. If they have any insurance and they're 50 to 80, they can go to U of C and enroll in the INSPIRE study. The FAN study is another one that's really interesting. As you may or may not know, probably do, the lung cancer incidence rate of female Asian never smokers is much, much higher than than the general population. So the FAN study is also currently enrolling patients primarily based out of California, but they are bringing in female Asian never smokers for annual lung screens to essentially test whether or not this is something that we should be offering to them. Are we going to decrease the lung cancer mortality rate by screening female Asian never smokers? So we've got a lot to look forward to, and there's been a long time coming. Does anybody have any questions? Yeah.
Can you tell me if you know the self-pay price
Sure.
for low-dose CT scan?
It varies by institution. Basically the requirement for self-pay is that we are not allowed to charge or be competitive with what Medicare is reimbursing for lung cancer screening. Right now, that's maybe $90. At Rush, we charge $139 for a self-pay screen. So if you're meeting the NCCN or ACS guidelines, that's a conversation that we are having with patients because they are considered high risk by those institutions. So that is something that is offered to patients at Rush.
Would they have to meet those requirements to just walk in and ask for a?
Not necessarily. There are patients that come in and screen for self-pay. We're not really strict here. Certain, it depends on the institution again. But if you are required to have an order from your provider. So there does need to be like a decision and a shared decision-making discussion with your provider for self-pay exams. If you don't meet any eligibility criteria, but we don't prevent people from screening, that have that order for self-pay from their provider. But self-pay is not self-refer. Yes.
For the fan study, was that any age with the Asian women or was there an age criteria?
There is an age criterion for the fan study. I believe it's 50 and up.
Oh,
I have a comment and a question. I know when I asked the PAC year, well, they're like, I don't know, I think it was 15 years or 20 years.
Yeah.
So it's like, okay, tell me 20, because then you're in the criteria. So what do you do in that case? And then also, secondhand smoke. I used to do orthopedic oncology. There were a lot of kids with cancers and, they didn't smoke, but their parents smoked a lot.
Yeah.
So is that a criteria that would be covered?
Would not be covered, but it is, encouraged to be discussed in shared decision-making and looking at it at that additional risk factor that is included in some of the risk prediction models. And in terms of addressing pack year smoking, like pack year history with patients, I find it easiest just to be honest with them. Like, I'm asking this question because there's a minimum requirement for you to get this exam. You have to have smoked a minimum amount to get this covered. I'm pretty frank with my patients about that because it helps take away some of that stigma. You might hopefully get a more honest answer from somebody if you're saying, I need you to have smoked more in order to be eligible for lung screening.
Like age questions,
Yeah.
right? Most people drink more than they think.
Exactly, yeah.
Or maybe
Right.
there's a time period where they're more stressed and smoke more,
Mhm.
and then, so maybe round up, because there's no way to prove that anyhow.
Yeah, I'm like, well, on the
Is
weekends,
that
did you
fine?
smoke more on the weekends? You can kind of get there.
I was just wondering, are there studies that's thinking about following younger population to help change the behavior of smoking? Because right now, you're smoking in grade school, you're smoking in high school, I think that would be a good population to start trailing because maybe that might be the opportune time to change that behavior so they don't become a statistic as they get older.
I think that's a wonderful idea. I haven't heard of any studies like that, but I honestly haven't done a lit search on like
Okay.
specific studies related to younger population that are smoking.
You know,
It could be,
Smoking could be, if the individual come from a house, like I came from a house where both my parents smoked, there's 5 of us and I'm the only one who don't smoke.
Mhm.
So, that doesn't mean something won't pop up because I'm in that 50 bracket thing. But I'm just thinking if the behavior could be looked and monitored and probably changed because, the way they're smoking and they're doing the e-smoking and they're doing the whatever creative things. And maybe find another way to change that behavior because smoking is a stress relief. So maybe we need to look at other ways to help them deal with stress.
A lot of information that's come out in terms of tobacco cessation supports referring patients for like some sort of medication to help them quit smoking, as well as some sort of other kind of psychosocial intervention, whether that be like one-on-one with a tobacco treatment specialist or group. We offer Courage to Quit here virtually for our patients. So yeah, that is a discussion that we have with them pretty much every week.
You want to share your information about the Lung Cancer Screening Network?
Sure. The Lung Cancer Screening Network, or the LSN, is a consortium of professionals and patient advocates that are involved in lung cancer screening at their institution or are interested in lung cancer screening. Our grassroots was originally founded here by my predecessor, the wonderful Linda Dowling. We meet every other month on a Wednesday from 12 to 1. We have a speaker every other month. It is totally free, where they'll provide some education about lung cancer screening or something that relates to lung cancer screening, whether that is a program that found an innovative way to overcome a barrier, something that's new and innovative that's rolled out, somebody that has a thought leader in lung cancer screening or cancer early detection. Even if you're looking to grow a lung cancer screening program at your institution, we have resources and have had people discuss like the business side of like, how do you justify the resources for lung cancer screening at institutions?
to know if you can share the questionnaire to assess smoking history.
Sure.
Maybe you could send to us. I'll touch that.
Yeah, Epic has one. I don't have like a formal questionnaire. Yeah, but I can write something up, kind of what we normally say, send it. Maria can send it.
We have one last question.
Yeah.
Are there any consideration for marijuana smoking?
Not right now. We don't have the data on it. It, again, is encouraged to be included in a shared decision-making discussion. And it is included in some of the risk prediction models, the independent risk prediction models, but it would not affect like coverage for lung cancer screening. And it doesn't affect like ACS or NCCN guidelines, other than it's encouraged to discuss.
I have one
Yeah.
question for you. When I, sorry, when I used to work with lung cancer screening years ago, there would be questions that would come up to me regarding the screening criteria.
Mhm.
Asymptomatic, what about if you do have symptoms? Why are the patients that have symptoms not included with the screening?
That's a wonderful question. Thank you for asking me. This is something that we still do discuss with primary care providers regularly. So to be symptomatic, where you would not be eligible for lung cancer screening, you have to have essentially symptoms of active lung cancer. You have to be losing weight without trying more than 10 pounds in a month, cough that will not go away, coughing up any blood. Those are kind of the big three excluders for patients that are coming in for symptoms for lung cancer. And the reason we don't recommend coming in if you have symptoms is this is a screening test. It's the lowest priority for radiologists to take a look at these exams. They're not reading them the same day. Sometimes they're not reading them the same week. Sometimes they're not reading them in the same 2 weeks. So if you have a patient that's coming in with symptoms, you want them to get a CT chest without contrast. Those are the exams that are going to be read before they start reading those lung cancer screening exams. Most institutions do a good job of making sure that they get them read as soon as they can, but things happen. We get backlogs. Radiologists are, there's only a finite number of them that are reading these exams, and we want to make sure that we're not delaying care because somebody is symptomatic and came in for the wrong exam. Oh, thanks.